यहाँ से करना है साइड से people से हमारा रजिस्टर भी है
उठेगा तब जब 9 o'clock में उठेगा
Good morning to all. Today's my topic is diabetes treatment guidelines. My moderator is Dr. Ansa Agarwal. First, we start from the classification of anti-diabetic drugs. They are classified into the category of drugs which increase the insulin secretions, other which increase insulin sensitivity and decrease glucose absorption, and last miscellaneous drug. Under the insulin secretion drugs, also known as insulin secretogens, which include sulfonylurea and DPP4 inhibitors, dipeptyl peptidase inhibitors, which increase insulin sensitivity are biguanides and thiazonalides. Drugs which decrease glucose absorption are alpha glucosidase inhibitor and miscellaneous SGLT2 inhibitor or dopamine D2 antagonist. Mechanism of action, the sulfonylurea which act on the potassium channel which inhibit and increase the calcium influx which cause insulin exocytosis, and DPP4 inhibitors which inhibit the DPP4 enzyme and increase the insulin secretion. Here in the chart, we see the biguanides. Mechanism of action: decrease hepatic glucose production, increase insulin sensitivity, influence gut function. The examples are metformin, which reduce the HbA1c level by 1 to 2%. Agent-specific agent, weight neutral, do not cause hypoglycemia, extensive experience in cardiovascular events. The disadvantages are diarrhea, nausea, lactic acidosis, vitamin B12 deficiency, and contraindications are the renal failure, in which the GFR reduced to 60 ml per 1.72 meters square area. Alpha glucosidase inhibitor decrease GI glucose absorption. Example ascorbase Miglitol reduce the SB1C 0.528. Advantages: reduce postprandial glycemia. Disadvantage: GI flatulence. DPP-4 inhibitors which prolong endogenous GLP-1 action, increase insulin, decrease glucagon, are aloxagliptin, sitagliptin, saxagliptin, vidalagliptin. SB1C reduced by 0.5 to 0.8. Advantage: well tolerated, do not cause hypoglycemia. Disadvantage: angioedema, urticaria. Insulin secretogens, sulfonylurea, increase insulin secretion, are glimepiride, glycoside, which reduce SB1C 1 to 2%. Advantage: short onset of action, lower postprandial glucose, inexpensive. Disadvantage: hypoglycemia, weight gain. Insulin secretogen, non-sulfonylurea, increase insulin secretion, are metaglutinide, netaglutide, which reduce HbA1c by 0.5 to 1%. Advantage: short onset of action, lower postprandial glucose. Disadvantage is hypoglycemia. SGLT2 inhibitors increase glucose excretion. Examples: canagliflozin, dapagliflozin, empagliflozin, which reduce SbA1c 0.5 to 1%. Do not cause hypoglycemia, reduce weight and blood pressure, also cardioprotective. Disadvantage: urinary and genitalium infection. Thiazolidines, which decrease insulin resistance, increase glucose utilization. Examples: pioglitazone, which reduce 0.5 to 1.4% of HbA1c. Advantage: lower insulin and requirements. Disadvantage: congestive heart failure, weight gain. And parental oral GLP-1 receptor antagonist and other parental are insulins. Then we start from the factors on which guidelines are determined. There are main aim of the antidiabetic drug are we reduce the HbA1c level 6.5 to 7%. Fasting blood glucose level 180 to 130 mg per dl, and postprandial was less than 180 milligram per dl. And some other factors which include efficacy, hypoglycemia, weight changes, cardiovascular effects, cost, and route or some disadvantages. In which we see there are the two drugs which cause weight gain are the sulfonylurea and other factor are cost. The metformin and sulfonylurea are low cost, and other drugs GLP, DPP-4 are costly drugs. Other we see the other comorbidity like atherosclerotic cardiovascular disease, heart failure, and renal disease. The SGLT2 inhibitors and GLP are we preferred in these cases. In the guideline, we see the first line therapy is metformin, irrespective of the other factors. Then we see the high risk categories in which include atherosclerotic cardiovascular disease, chronic kidney disease, and heart failure, in which we either giving the patient GLP-1 or SGLT2 inhibitors. Then we saw the target of the HbA1c level. If the HbA1c level was not controlled, then we include GLP-1 or SGLT2 plus any other DPP-4 or thiazolidine or sulfonylurea. In case of heart failure with reduced ejection fraction or left ventricular ejection fraction less than 45%, we are giving SGLT2 inhibitors. In chronic kidney disease patient, we prefer SGLT2 inhibitors or GLP-1 inhibitors. In case there is a patient who are prone to hypoglycemia, we are preferred the drugs DPP-4 inhibitors, GLP-1, SGLT2 inhibitors, and thiazolidine. In case if the single drugs are not control the HbA1c level. We are prefer the combination of two drugs which either in rest of force. If we want to minimize the weight gain or promote weight loss, their sulfonylurea and thiazolone are contraindicated. Rest of drug we are given. In case of cost is a major issue, we are prefer sulfonylurea and thiazolone. If HbA1c level above target level, then insulin therapy is started. A reference from the Anion Diabetes Guideline 2021 and Harrison 24th edition, Principle of Internal Medicine. Thank you.
Good morning, everyone. Myself, Gavakshi. I am presenting the topic Hypertension Treatment Guidelines, and my moderator is Dr. Ayushi. What is hypertension? Clinically, hypertension may be defined as that level of blood pressure at which the institution of therapy reduces blood pressure-related morbidity and mortality. Clinical criteria for defining hypertension generally have been based on the average of 2 or more stated blood pressure readings during each of 2 or more outpatient visits. Blood pressure classification. When the systolic BP is less than 120 millimeter of mercury and diastolic is less than 80 millimeter of mercury, then that is normal blood pressure. When the blood pressure ranges between 120 to 139 and 80 to 89, it is known as prehypertension. Stage 1 hypertension, in which the systolic blood pressure is between 140 to 159 and diastolic is between 90 to 99. Stage 2 hypertension, in which there is systolic BP is more than equal to 160 and diastolic is more than equal to 100. Isolated systolic hypertension, in which systolic BP is more than 140 and diastolic is less than 90 millimeters of mercury. Treatment. There are lifestyle interventions and pharmacological interventions. In health promoting lifestyle modifications are recommended for individuals with pre-hypertension and as an adjunct to drug therapy in hypertensive individuals. Dietary modifications that effectively lower blood pressure are weight loss, reduced salt intake, increased potassium intake, moderation of alcohol consumption, and an overall healthy dietary pattern. Pharmacological therapy. Lowering systolic blood pressure by 10 to 12 millimeter of mercury and diastolic by 5 to 6 millimeter of mercury confers relative risk reduction of 35 to 40% for stroke and 12 to 16% for congenital heart for CHD within 5 years of initiation of treatment. The risk of heart failure is reduced by more than 50%. Hypertension control is the single most effective intervention for slowing the rate of progression of hypertension-related kidney disease. Selection of antihypertensive agents is according to age, severity of hypertension, other cardiovascular disease risk factors, and comorbid conditions. Some antihypertensive agents are diuretics, like thiazides. Low-dose thiazide diuretics may be used alone or in combination with other antihypertensive drugs. Thiazides inhibit the sodium chloride pump in the distal convoluted tubule and hence increase sodium excretions. They are safe and efficacious blockers of the renin-angiotensin system. ACE inhibitors decreases the production of angiotensin 2, increase bradykinin levels, and reduce sympathetic system activity. Angiotensin receptor blockers provide blockade of angiotensin 2 receptor type 1 and effect of angiotensin 2 on unblocked angiotensin 2 receptor type 2 may augment their hypertensive effect. Aldosterone antagonist. Spironolactone is a non-selective aldosterone antagonist that may be used alone or in a combination with thiazide diuretic. Beta blockers. Beta adrenergic receptor blockers lower blood pressure by decreasing cardiac output owing to reduction of heart rate and contractility. Alpha adrenergic blockers. Postsynaptic selective alpha adrenoreceptor antagonists lower blood pressure by decreasing peripheral vascular resistance. Sympatholytic agents. Centrally acting alpha-2 sympathetic agonists decrease peripheral resistance by inhibiting sympathetic outflow. Calcium channel blockers. Calcium antagonists reduce vascular resistance through L-channel blockade, which reduce intracellular calcium and blunts vasoconstriction. Direct vasodilators. Direct vasodilators decrease peripheral resistance and concomitantly activate mechanisms that defend arterial pressure. Comparisons of antihypertensives. Meta-analysis of the efficacy of different classes of antihypertensive agents suggests essentially equivalent blood pressure lowering effects of 6 major antihypertensive agents that are thiazide diuretics, beta blockers, ACE inhibitors, angiotensin receptor blockers, calcium antagonists, and alpha blockers. On an average, standard dose of most antihypertensive agents reduce blood pressure by 8 to 10 of systolic and 4 to 7 of diastolic millimeters of mercury. Younger patients may be more responsive to beta blockers and ACE inhibitors, whereas patients aged more than 50 years of may be more responsive to diuretics and calcium antagonists. A meta-analysis of more than 30 randomized trials of blood pressure lowering therapy indicates that for a given reduction in blood pressure, the major drug classes seem to produce similar overall net effect on total cardiovascular system. In specific patients groups, ACE inhibitors may have particular advantages beyond that of blood pressure control in reducing cardiovascular and renal outcomes. ACE inhibitors and angiotensin receptor blockers decrease intraglomerular pressure and proteinuria and may retard the rate of progression of renal insufficiency in both diabetic and non-diabetic renal diseases. ACE inhibitors provide better coronary protection than do calcium channel blockers, whereas calcium channel blockers provide more stroke protection than do either ACE inhibitors or beta blockers. The combination of an ACE inhibitor and a diuretic has recently been shown to produce major reduction in morbidity and mortality in the very elderly. After a stroke, combination therapy with an ACE inhibitor and a diuretic, but not with an angiotensin receptor blocker, has been reported to reduce the rate of recurrent stroke. References are taken from Harrison's Principles of Internal Medicine. Thank you.
Good morning, everyone. I'm Diksha, presenting the topic of drug tramadol, and my moderator is Dr. Abhishri Ranjan. The overview of the topic is introduction, opioid receptors and their effect, mechanism of action, doses, indications for use, side effects, tramadol overdose, and lastly references. Introduction. Tramadol is synthetic codeine analog that is weak mu receptor opioid agonist. Part of its analgesic effect is produced by the inhibition of reuptake of norepinephrine and serotonin. That means it increases the 5-HT release and thus activates the monoaminergic spinal inhibition of pain. Its analgesic action is only partially reversible by opioid antagonist naloxone. Opioid receptors and their effect. Mu receptors, if some drug is acting on mu receptors, there will effect of analgesia, sedation, meiosis, urine retention, respiratory depression, inhibition of gut motility, increased muscle tone, and immune suppression. On kappa receptor, the effects are analgesia, sedation, dysphoria, diuresis, meiosis. On delta receptors, there is mainly analgesic effects. Mechanism of action. Drug tramadol has a dual mode of action. Firstly, it binds to weakly binds to mu opioid receptor sites. Affinity for the mu opioid receptor is 1/6000 that of morphine and 1/10 that of codeine. It inhibits the reuptake of norepinephrine and serotonin. The parent compound is a racemic drug with both enantiomers of plus and positive and plus and minus forms that play important role in its mechanism. The plus enantiomer has a high affinity for the mu receptors and increases the serotonin level. The minus enantiomer increases the norepinephrine level. The metabolite, primary metabolite, M1 metabolite, is the O-dimethylated form of tramadol with plus enantiomers form having greater potential for analgesic effect, that is 6 times that of parent drug. There is isoenzyme of cytochrome P450, that is CYP2D6, that is responsible for the conversion of M1 metabolite. Tramadol, the drug tramadol is converted to M1 metabolite with the help of this isoenzyme CYP2D6. Some of the population, like 7% of the population, lack this isoenzyme. Therefore, the tramadol metabolizes poorly and provide decreased analgesia. Tramadol is 68% bioavailable after a single dose and 100% available when administered intramuscularly. The compound undergoes hepatic metabolism and renal excretion with elimination of half-life of 6 hours of tramadol and 7.5 hours for M1, that is primary metabolite of tramadol.
Can you please put like one? Calendar.
Then doses of the drug. The average dose for a healthy adult is 50 to 100 mg every 6 hours. The maximum recommended daily dose is 400 mg of tramadol. Analgesia begins within an hour of oral dosing and peaks within 2 to 3 hours. Oral preparations like we use tablet Ultracet Urgindol contains tramadol of 75 mg and 325 mg of acetoaminophen. Indication for use of tramadol. Tramadol is indicated for mild to moderate or short-lasting pains and less effective in severe and chronic pain. We can use in malignant pain, osteoarthritic pain, low back pain, diabetic neuropathy, fibromyalgia, pain from surgical and dental procedures, and it can also use in labor pain and also causes less neonatal respiratory depression. Common side effects are dizziness, lethargy, headache, nausea, vomiting, and constipations are common complaints after the first week of uses of drug. Respiratory depression is also the side effect, but although this is less than equianalgesic dose of morphine. Morphine causes more respiratory depression. However, as we studied earlier, that naloxone cannot completely reverse the effect of tramadol, but however it can reverse the respiratory depression that caused by tramadol. Tramadol can cause seizures and possibly exacerbate seizure in patients with predisposing factors. Physical dependence on abuse of tramadol have been also reported. Tramadol should avoid in patients with history of addiction. Tramadol can cause serotonin syndrome if given to the patient taking SSRI therapies due to increase in serotonin level. The serotonin syndrome occurs due to increase in serotonin levels. There can be changes in mental status and neurological changes like increase in muscle tone, tremors, ataxia, agitation, hypomania. Some mental status changes are like fever, shivering, nausea, vomiting, and diarrhea. Tramadol overdose. Respiratory depression started at 500 mg of dose, and coma can occur at 800 mg of dose. Opioid overdose is characterized clinically by unconsciousness, a low respiratory rate, pinpoint pupil, apneic or cyanosis, cold and clammy skin. Blood pressure first likely to near normal and will fall progressively. Examination of urine and gastric content for the drug level may aid to diagnosis, but result usually become too late to start treatment. Treatment for overdose. We have to firstly we have to establish a patent airway and ventilate the patient, and we have to give some opioid antagonists like naloxone that can reverse some of cardiopulmonary effects of tramadol. Safest approach is to dilute naloxone dose 0.4 mg and slowly administer it intravenously, monitoring arousal and respiratory functions. References. Pharmacological basis of Goodman's and Gilman's 13th edition and modestly prescribing guidelines in psychiatry for 14th edition. Thank you.
Being users of his role as placement rather than directly. Weight loss. Weight loss. Aging effect. Pre-hypertension can be given into next day. Then how much weight loss can work? Most of them can work as weight loss. Even if you lose 3 to 4 kilos, somebody very active, just losing 3 to 4 kilos of weight can see. Tramadol is very erratic thing. Erratic thing. आपने बोला कि naloxone सिस्टम जो है respiratory depression को न्यू रिसेप्टर्स भी किस पे करता काम ये सिर्फ एक न्यू रिसेप्टर के सप्लाई then or can it be used in the can it be but it can cause रोज आपने बताया पैरासिटामोल के साथ पैरासिटामोल के साथ अल्ट्रासेट इंटरनेशनल प्राइस hospital. So usually paracetamol then no more 325 analgesic dose वैसे अगर आप paracetamol high dose में इसलिए देते क्योंकि वो All of you presented very well. On undergraduate. Celebrities. Psychiatry department में ठीक है, okay. कुछ ऐसा करते हैं कि खड़े होकर के कर पाए प्रेजेंट। लैपटॉप करते हैं। अच्छा, आप पॉइंटर से साइड चेंज कर सकते हैं, है अपने पास में?
जब भी कोई गेस्ट लेक्चर आता है
ओके। नहीं, उसकी एक्चुअली प्रॉब्लम ये है कि या तो कोई वायर्ड पॉइंटर सिस्टम है, लेकिन वो खो जाएगा। ये तो है। यहाँ बना लें पार्सल के सिस्टम वाला है तो यूज कर लेंगे। ठीक है।
कोई मतलब